Hello, everyone. I'm Vanessa Grossel, Policy Analyst at the Council of State Government. I'm the staff liaison to our Capacity Preparedness and Resiliency Subcommittee of CSG's Healthy States National Task Force. The subcommittee is focused on building resilient communities that are able to prepare for, respond to, and recover from both community-level disasters and public health crises. I'm joined today by Dr. Lee Norman, Kansas Secretary for Health and Environment, to talk about the coronavirus and state government's role in building community resilience. Dr. Norman received his medical degree from the University of Minnesota, did his residency in family medicine in Texas, and his aerospace medicine training in the United States Air Force at Brooks Air Force Base in San Antonio. After serving in the Air Force as a family physician, flight surgeon, and combat medicine instructor, he practiced medicine in Seattle for 20 years, also serving as clinical associate professor at the University of Washington School of Medicine. He has served as a chief medical officer for over 26 years, most recently at the University of Kansas Health System. He is currently clinical assistant professor at the University of Kansas School of Medicine and is a colonel in the Kansas Army National Guard. As the state surgeon of Kansas, he guides medical troop sustainment and training, health services support, force health protection, biosecurity, and serves as advisor and liaison to the Kansas Department of Emergency Management and Homeland Security. So Dr. Norman, welcome. Tell us what you know about COVID-19 and its relationship to other coronaviruses of the past. Did you see this coming?
Sure, happy to talk about that. And answer the question first, no, not really a coronavirus necessarily. I've been involved in, as you mentioned, in disaster preparedness and biological threat for a long time. I've originally, remember the light went off in 1976 when Ebola first hit the news, but that was, as you may remember, was a long time ago in a faraway land called Africa. And I said, well, we're on a banana peel here as people start traveling more, as more flights become routine globally, and as population increases in size, there's always going to be a bio threat. So run the tape forward to H1N1 in 2009. Before that, SARS, which was a coronavirus in 2003 and 04, Ebola again in 14, and then this. We've been watching this for a long time and had the suspicion that a pathogenic virus and a novel virus, something that's of a new genetic structure, was going to happen. We watched from both the human impact. We look at it, I'm in an agricultural state, and we also follow it very closely in the food animal, like cattle and hogs and chickens, for example, and also plants. And we were particularly watching China, and I think if I would have been asked to commit a year ago, and somebody would have said, what's the next pathogen going to be that's going to be an epidemic or a pandemic, I would have said probably an influenza virus, an H5N1, or one of the new emerging avian flu. And it was a little surprising to me that it was a coronavirus, although in retrospect, maybe we could have seen that coming. The Middle East, you may have heard or read for a number of years, we're now in year number 7 of the Middle East Respiratory Syndrome-CoV. The MERS-CoV is a coronavirus, and it came on like gangbusters 7 years ago and is still an endemic problem in the Middle East. I was Army deployed in a medical command role in 2017 and 2018 in the Middle East, and that coronavirus there, which is a human pathogen, has become so kind of firmly entrenched, I guess I would say, that when somebody comes into the hospitals, whether it's Kuwait or Jordan or Oman or points between, it's been around long enough there now that people just automatically test for influenza and coronavirus for those severe respiratory illnesses causing intensive care, and it has a very high mortality rate, almost 40%. So there's a couple lessons that have been, more than a couple lessons that have been learned from the MERS-CoV, and it may or may not portend what to expect here from a forecasting perspective. The MERS-CoV didn't peak out until its 4th year. So I would hate to think that what we're doing now is just a run-up to something that will peak out in year number 4, but our preparedness work and our work towards vaccine and antiviral medications is very serious, lots of allocated funds, and I think that we will get better prepared as time goes on, but with good containment and vaccines and medications, I would love to see this go away. But we don't know what the trajectory of that will be yet, and we don't know if it will be seasonal. You know, the influenza for the most part is seasonal, comes on in, you know, October, November, usually pretty well dissipates by about March and April, goes away in the late spring, summer, fall. We don't know that this coronavirus will act that way. Again, it's a respiratory virus, but we don't know if it's going to be seasonal or not. I'd love to see it go bye-bye in about, well, now or soon, and have a reprieve from it. Because right now it's really what I would call unmitigated, except for the good public health things and the policy things about distancing and limiting groups and things like that. It's rather unmitigated in the sense that there's no vaccine or medications. So if we model it like we did, let's say we looked at influenza in 1918, the Spanish flu, which was an unmitigated influenza, then it comes out with wildly high numbers for the coronavirus in the United States. And again, keep in mind, influenza and coronavirus are two completely unrelated viruses. But for how they spread in similar way through coughing and surfaces. So a little bit of a lengthy answer to your question, Vanessa, but we weren't surprised to see a biothreat such as this. We were not surprised to see it come out of China, but was not sure that it was going to, I'm surprised a little bit that it's a coronavirus and not a novel influenza. So there you go.
Thanks. One of our subcommittee members actually wrote in with this question: how do we deploy the test kits for communicable diseases such as COVID-19 fast enough to catch the spread earlier?
Yeah, there was definitely not enough testing kits and materials available at the very beginning. And that did have an impact on the response. We're getting better now because there's some commercial companies that are online now that provide service. So that'll take some of the pressure off of the test kits that came to us through a distribution process in cooperation with the CDC. We did not run out in Kansas. And really, testing there's 3 or 4 parts. One is you have to have staff that can gather the sample from the person, which is a nasal swab, and it has to be done correctly, and an oral swab. And then you put it into what we call viral transport medium, and then courier it over to the lab. So step 1 is using the swabs and the viral transport medium. We're a little short on that. We haven't run out. The next step goes through a complicated testing process with DNA extraction, and that uses the test kit itself. We are low in supplies of those, but have not run out. And then, of course, it goes through the machinery, and I had a tutorial here recently on it. It's pretty complicated, but it does 2 things, and it gives you the answers, yes or no, coronavirus is there, but it also has a control in there that says this is a good sample or not a good sample, because if it's a well gathered sample, it'll have human DNA from the person's nose or mouth. And in the absence of DNA, you can't say much about the test being positive or negative. So that would be what I would call it, quality control. And then you have to have lab techs that know this, because it's called a PCR test, the method. And the lab techs that do this don't grow on trees. And I'm glad we've had enough to keep up with the demand, because the demand has doubled every day, really, in the last 10 days or 2 weeks. But we're really glad that commercial companies are coming on board and will help to take some of the burden off of us. And because we used to always give same-day service. If we got it by mid-morning, we'll say, we would have the test results at the end of the day. But now with the doubling and redoubling of the demand, it's stretched out to a couple or 3 days, which is not ideal, because that means somebody's out there in a hospital or at home waiting for that information. But hopefully we'll get back to our standard that we want. Is the test takes 4 to 6 hours to run, and then we'll do the turnaround to get the information back to the person who ordered the test as quickly as possible.
Great. What other kinds of preparation efforts are still needed, or in hindsight, now that the outbreak is upon us, what would have been helpful earlier on to mitigate some of the impacts and reduce risk?
Well, if we go way back, it's a real good question. If we go way back, I think that the SARS, the severe acute respiratory syndrome, was mostly a disease of the Far East, of the Eastern Asia, in 2003 and 4. It came on like gangbusters, caused all manner of mayhem, and then it kind of went away very quickly. And there was a frenzy of activity to create a vaccine for that coronavirus, but it was no longer commercially viable. You know, companies didn't want to do the development work. Maybe in retrospect, we should have, as a nation, as a Congress, allocated monies like to the NIH and others, and other academic institutions to deliver the coronavirus technology into a vaccine. So now we find ourselves scrambling to kind of go back to square one on vaccine development, because that's a laborious process and takes a lot of testing for both safety and also for efficacy that it works. So I don't think we're going to see a vaccine anytime soon. I think it could be as much as 6 months, or I should say as early as 6 months, or late as a year or more. So I think that's the primary one. I think we kind of had a wake-up call with H1N1 when it came to develop to having masks, gowns, gloves, face shields, etc., PPE, personal protective equipment. And yet that stuff is very expensive. You put it in a strategic warehouse to have it for this kind of event. You have to inventory it, and you have to make sure that it remains of good quality. You know how elastic over time loses its effectiveness. And I think that it was kind of the human, if something is not right in front of us and we're not paying attention to it, it's not in the current news, then after a while we say, do we really need to spend $800,000 a year on replenishing that? So I think the second one is always vaccine development, number one, and then second is always making sure that the strategic stockpiles for personal equipment are there for when we need them, when we have a bad day, like we're having now.
Thank you. What kind of impacts do you see this having on states in the short and long term?
Well, a lot. And I actually think that this is going to impact, one, for a very long time, and two, I think it's going to impact every aspect of our life. I think that social customs are changing in terms of shaking hands and being in very, very close approximation. I think from a public health perspective, I think what kind of messaging that we need to do. And I think that people have to learn how to stay home when they're sick and not, tough it out and infect others. We had a great example of that is last week we had a patient that came out positive for it, and this particular individual who knew she was sick, had a fever, decided, it's probably just a cold or something. Even with all this public messaging going on, went to a gathering. And now we have got 3 new people that were all at that gathering that came up positive last night. So we have 3 new patients here. And, the old adage, stay home when you're sick, when it's violated like that. In this case, we've had 3 so far. There might be more. And then each of those 3 might well infect 2 or 3 more people. So, but there's also things, I think this is going to stimulate, back to your question, it's going to stimulate working from home and telecommuting. I think that'll stimulate that technology. I think with schools, I think it could have impact on what class sizes can be. I think with parents, what do we do if we have to keep kids home? What can they learn at home? Is there distance learning opportunities, whether it's K through 12 or colleges and universities? What about travel? What about working abroad? At least for the short run, those things are going to be badly impacted. HR policies. What happens if you have to work from home? Do you get to, are you paid? Do you have to burn your paid time off? Do you take it as vacation time? I mean, I think we're blowing the dust off of a lot of HR policies as well. I think one more thing, and this is very much in your wheelhouse for public policymakers, is how much do we invest in public health? And because we have a very dated laboratory, for example, in Kansas, and we're working with the legislature to build a new lab. It's an ancient facility that's outmoded, but just we're barely making it anyway with all the sexually transmitted illnesses and chronic diseases. We're built for what I call phase 0, which is just everything's fine, thank you very much. How do we flex up in a time that's in a pandemic like that? We don't have any redundancies that allow us to flex up very well. So I think staffing will get looked at.
Thank you. My next question was actually, what would you want state leaders to know about COVID-19 and possible future infectious disease outbreaks?
I think the old adage about in time of peace, prepare for war. I think that we in public health have not really been as demanding as we should be about the kinds of funding levels and the kind of competencies we need. So I would say, one, I think this underinvestment in public health, we've reaped what we've sown, and here we are. I think another one is and I think for policymakers, disasters start locally and end locally. And one of the things that is really critical, and I think about it a lot, is we have 105 counties in Kansas, 100 health departments. Am I giving them, and does our legislature, does the federal government provide grants that are sufficient for what they need to do the public health work at the local level? Because I kind of use the term that they're kind of closest to the bedside. I think it's one thing to have smart people in a state building, but where the rock and roll is happening, quite honestly, is out at the bedside, out at the local level. And I think we need to be attentive to saying, how can we distribute the funds differently? I think also it's really important to have really good role clarity. Not long ago, I was down in Emporia, Kansas, a nice medium-sized community with a college, and we drilled on a highly infectious disease patient. It was a simulation, but it started out at the patient's bedroom, literally, involved EMS, a local hospital, physicians, et cetera. So we took the whole day and went through it, and it was really good. I was down there as an evaluator, and it was really good for road testing to make sure that we didn't have any chinks in the armor. My buddy up in Washington, John Wiesman, who's my counterpart in his role in Washington State, of course, they had coronavirus, came on early and in a bad way. He said the virus will find every defect. If there's any way that metaphorically, any way that the virus can wiggle its way, and it's going to wiggle its way. And so all the processes, all the practices have to be airtight.
Okay. And are there other things that you think of in particular that relate to state legislatures in terms of ways that they can improve resiliency and better prepare for all sorts of future emergencies?
Yes, I do. And I sympathize in a sense with legislators, because when you invest in public health and nothing happens, you say, well, we're obviously over-investing in public health because nothing's happened. And that's a faulty thinking. The best disasters are the ones that never happened. And for example, if this could have been contained in China or contained in Europe and not made it here at all, we would have been much happier and much safer here. A good example is that the administration cut back on CDC funding in Europe, and I should say globally, CDC. Our CDC forever has had significant presence in other countries to work with those countries to mitigate diseases there. That was cut back severely a few years ago by our current administration. And I think now there's the belief that, well, maybe that was a bit hasty. Granted, it's always 20/20 hindsight. But I think that it's the public health responsibility to inform legislators what do we need. I think we also have to be very specific and not just use broad generalities. We want to keep Kansans healthy. Okay, that's fine. What are you worried about? What do I worry about? I worry about avian influenza, the crowding of chickens, and the fact that there can be DNA in the viruses that then jumps from animals into humans. Here's how we can mitigate it. Here's how we work with Department of Agriculture and others. I think we have to, in public health, we have to get more of an activist stance so that we communicate with the legislators what is it that we really need to do the job, what is the job, and then celebrate when we don't have bad things happen. I've been predicting for years that biothreat is or epidemics or pandemics is a threat to our national security, and I've not backed down at all on this, and let alone our economic security. You've seen what's happened with this virus in terms of the huge economic impact, and now we're talking about closing, and restaurants are being closed, and stock markets, fallen, and I mean, I think this is going to be a wake-up call. I don't think it's ever going to be the same after this in terms of the attentiveness to what is it that we need to do to keep the public safe and to keep these things from happening.
All right, before we go, do you have any other thoughts to share on building community resiliency or other topics that you wanted to bring up during our call?
Well, I think, first off, I'm very complimentary of you and your organization and the legislators from all over that are even thinking about this. Sometimes we have a hard time getting airtime on public health. It's easy now where everybody's darling, but people also, legislators and the public alike, have short attention spans, and when it's kind of under control, then we're going to move on to the next thing. And social media makes us have a short attention span. So one of the things that I would like to kind of remind us all is that we're in this for the long haul, not just for this pandemic, and this is a pandemic, call it what it is, but how do we prepare for the next one and the next one after that? And some of that, you go in the business here, it goes under continuity of operations or COOP plans. Nobody wants to do COOP plans, continuing plans, because it's around IT and human resources, everything from transportation, parking, law enforcement. When a bad situation like this comes up and we invoke those COOP plans, how do we even stay in business? How do we run a state government? So I think one of the things the legislators can say is, what happens if somebody came in with coronavirus in the house? We have 140 people sitting within 2 feet of each other. Can we run our legislative agenda from home? Because you're one ill person away from adjourning for no matter where you are in the session. If you've got a disease spreading through the legislature. And I tell you, we're almost coming up to a break in the session here there's a whole lot of motivation to finish this early and get the budget passed and get the heck out of Dodge and come back in for the veto session at the end of April. And so I think that we just have to have a steely-eyed look at it and say, what are the things that are likely? And then you never can eliminate risk. But I think we have the responsibility in working with legislators to say, where are the risks? How material are they? And what are the mitigating strategies? That, I think, is what we need to do.
Thank you, Dr. Norman, for joining us today, and we commend you for your work. I appreciate you for making time during this extremely busy time in your life to share your expertise, which will help greatly to inform the work of our subcommittee and task force. I'm Vanessa Grossel at CSG headquarters in Lexington, and I have been speaking with Dr. Lee Norman, Kansas Secretary of Health and Environment.